This is Chapter 34 from Med-Surg Timby, Caring for Clients with Immune-Mediated Disorders. Learning objectives. Describe an allergic disorder. List 5 examples of allergic signs and symptoms. Name 4 categories of allergens and give an example of each. Give 4 examples of allergic reactions, including 2 that are potentially life-threatening. Describe diagnostic skin testing. Name 3 methods for treating allergies. Discuss the nursing management of a client with an allergic disorder. Explain the meaning of autoimmune disorder and give at least 3 examples of related diseases. Discuss theories that explain the development of an autoimmune disorder. Name 3 categories of drugs used in the treatment of autoimmune disorders. Discuss the nursing management of a client with an autoimmune disorder. Give 2 explanations for how chronic fatigue syndrome develops. List common symptoms experienced by people with chronic fatigue syndrome. Name common nursing diagnoses, desired outcomes, and related nursing interventions for clients who have chronic fatigue syndrome. Allergic disorders. Allergic disorder is characterized by a hyperimmune response to weak antigens that usually are harmless, characterized by the manner in which the allergen gains entry to the body and the intensity of the response. Allergens are antigens that cause an allergic response. Allergies can occur at any age. Types of allergies include ingestants, food and drugs, inhalants, house dust and mites, and smoke, contactants such as latex, and injectants such as drugs and bee venom. Allergy examples include allergic rhinitis, contact dermatitis, food allergies, urticaria, which is hives, and angioedema, which is swelling of the face, head, and neck. Pathophysiology and etiology. More than 50 million Americans have 1 or 2 more allergic disorders. The 5th most common cause of chronic disorders in the U.S., Asthma and Allergy Foundation of America. The tendency to develop allergies can be inherited. Although members of the same family may have allergies, they may not all be sensitive to the same allergens. Allergy-prone individuals may react to more than one type of antigen. For example, the same person may be sensitive to ragweed pollen and eggs. The first exposure to an allergen does not produce symptoms. Rather, it causes sensitization. Sensitization is the process by which cellular and chemical events occur after a second or subsequent exposure to an allergen. Once sensitization occurs, one of 4 types of hypersensitivity responses can occur. These may be immediate or delayed, depending on the time it takes for the immune system to mount a response. Immediate hypersensitivity responses, types 1, 2, and 3. An immediate hypersensitivity response is due to immunoglobulin antibodies interacting with allergens and occurs rapidly. There are 3 types of immediate hypersensitivity responses. Type 1, atopic or anaphylactic, which is mediated by immunoglobulin E, which is abbreviated IgE antibodies. Type 2, cytotoxic, which is mediated by immunoglobulin M or G, IgM or IgG antibodies. And type 3, immune complex, which is mediated by IgG antibodies. The first 2 types of responses occur within minutes. Type 3 responses reach a peak within 6 hours after exposure to an allergen. In type 1, the most severe of the 3 immediate hypersensitivity responses, IgE antibodies attach to basophils or mast cells. Mast cells are constituents of connective tissue that contain granules of heparin, serotonin, bradykinin, and histamine, the most potent chemical of this group. With subsequent exposures to the allergen, mast cells and basophils release their vasoactive granules, causing various allergic and inflammatory manifestations. Anaphylaxis is a rapid and profound type 1 hypersensitivity response. A massive release of histamine causes vasodilation, increased capillary permeability, angioneurotic edema, which is acute swelling of the face, neck, lips, larynx, hands, feet, genitals, and internal organs, hypotension, and bronchoconstriction. Delayed hypersensitivity response, type 4. A delayed hypersensitivity response is also termed a type 4 hypersensitivity response. Antigens are initially phagocytized by macrophages. Sensitized T cells then produce cytokines that cause an inflammatory reaction. Antibody production is not a component of delayed hypersensitivity response. A delayed hypersensitivity response may develop over several hours or days, or it may reach maximum severity after repeated exposure. Examples of a delayed hypersensitivity response include a blood transfusion reaction that occurs days to weeks after blood administration, rejection of transplanted tissues, and reaction to a tuberculin skin test. Delayed hypersensitivity may also explain how people who have been in contact with latex multiple times without showing evidence of an allergy may develop an allergic reaction. Common allergens, ingestants, food, peanuts, milk, wheat, eggs, fish, drugs, aspirin, sulfonamides, antibiotics, especially penicillin. The common reaction to those is gastroenteropathy, dermatitis, asthma, anaphylaxis, urticaria, angioedema, and serum sickness. Inhalants, another common form of an allergen. Examples: house dust and mites, insect excrement, animal products such as dander, saliva, urine, pollens, and spores. Common reaction: allergic asthma, rhinitis, hypersensitivity, pneumonitis. Contactants, examples are plant oils, topical medications, occupational chemicals, cosmetics, metals and jewelry and clothing fasteners, hair dyes, and latex. Common reaction: contact dermatitis, urticaria, or anaphylaxis. The anaphylaxis is rare. Injectants, examples are drugs and bee venom. Anaphylaxis can occur, angioedema, and acute urticaria. Types of allergies are found in Table 34.2 on page 559. Question: as the nurse assesses the client, which of the following is a symptom that the client with anaphylaxis may be experiencing? A, dermatitis, B, delirium, C, sinusitis, or D, wheezing? The answer is D, wheezing. Anaphylaxis is a rapid and profound type 1 hypersensitivity response. A massive release of histamine causes vasodilation, increased capillary permeability, with severe symptoms of angioneurotic edema, which is acute swelling of the face, neck, or internal organs. And there's a picture of a woman that's having a reaction on page 560 in TIMBY MedSurg. Suppression of the allergic response. The body suppresses the allergic response through various mechanisms. One method involves the release of eosinophil chemotactic factor, abbreviated ECF, a chemical mediator, from mast cells. Chemotaxis refers to the process of attracting migratory cells to a particular area in the body. ECF, again, eosinophil chemotactic factor, attracts eosinophils, whose role is to suppress inflammation by degrading histamine and the other vasoactive chemicals. Epinephrine, a neurotransmitter, interferes with the release of vasoactive chemicals from mast cells. Corticosteroids, which are anti-inflammatory hormones produced by the adrenal cortex, block the synthesis of prostaglandins and leukotrienes, also known as slow reactive substance of anaphylaxis. Both these substances contribute to vascular permeability and smooth muscle contraction. Assessment findings. Signs and symptoms. Manifestations of anaphylactic reactions include shock, laryngeal edema, wheezing, stridor, tachycardia, and generalized itching, as well as hypotension, bronchospasm, and angioneurotic edema, as described previously. Less severe localized hypersensitivity responses can include watery eyes, increased nasal and bronchial secretions, sneezing, vomiting, and diarrhea. Additional symptoms include hives, urticaria, itching, and localized redness in the conjunctiva of the eyes. Dark areas under the eyes, referred to as allergic shiners, which are due to the accumulation of blood around the orbit of the eye, may also be apparent. Clients often identify a cause and effect relationship between particular substances and their allergic symptoms. Clinical manifestations generally correlate with the manner in which the allergen enters the body. For example, inhaled allergens, usually cause respiratory symptoms, including nasal congestion, runny nose, sneezing, coughing, dyspnea, and wheezing. Inhaled allergens often trigger asthma. Contactants cause skin reactions such as hives, which appear as vesicles filled with clear fluid surrounded by a margin of redness, rash, and localized itching. Cramping, vomiting, and diarrhea are associated with ingested food allergens. Injectants such as bee venom and some other allergens can produce systemic and potentially fatal effects, including shock and airway obstruction caused by laryngeal swelling. Clients exhibit the same reaction with each exposure to the allergen. Assessment findings in review: less severe localized hypersensitivity includes watery eyes, increased nasal and bronchial secretions, sneezing, vomiting, diarrhea, hives, which is called urticaria, itching, localized redness, dark areas under the eyes. Ingested food allergens causes cramping, vomiting, diarrhea, and injectants such as venom produce systemic, potentially fatal effects, cause shock and airway obstruction. Diagnostic findings. Diagnosis of an allergy may be simple and clear-cut, or may require multiple tests and extensive history taking. Diagnosis becomes difficult when a client is allergic to more than one substance, or when symptoms vary with fatigue, emotional stress, or the seasons. Radioallergosorbent blood test. Various abnormalities in blood test results suggest an allergic disorder. For example, the eosinophil count may be elevated. When the radioallergy or sorbent blood test, RAST, which measures IgE on a scale of 0 to 5, indicates a score of 2 or greater, it is a significant indication for an allergic disorder. The RAST test does not identify those, if any, substances to which a person is allergic. It only validates that the person is potentially hypersensitive to antigenic substances. Skin tests. Specific allergens can be identified by skin testing with extracts of various substances called antigens, such as pollens, animal dander, food, dust, and stinging insects. The three methods of skin testing are the scratch or prick test, the patch test, and the intradermal injection test. The scratch or prick test involves scratching the skin and applying a small amount of the liquid test antigen to the scratch. The tester applies one allergen per scratch over the client's forearm, upper arm, or back. The back is more sensitive than the arms. It also provides a larger area for testing, because each substance being tested should be distributed at least 3 centimeters and preferably up to 5 centimeters, slightly more than 1 to 2 inches from one another. Results from a scratch test are identifiable in as little as 20 minutes. If a raised wheal, WHEAL, with its length it raises a wheel with localized erythema appears, so it's raised and it's red. The tester measures its length and width in millimeters. The larger the reaction, the greater the likelihood that the test allergen is the cause of the symptoms in the tested person. The patch test is used to identify the offending substance in allergic contact dermatitis. The tester applies a concentrated form of the substance to the skin and covers the area with an occlusive dressing. After 48 hours, the tester removes the dressing and examines the area for erythema, edema, and vesicles. There's a picture of wheals on page 562 in TIMB, figure 34.6. In the intradermal injection test, which usually is performed only when results of a scratch test are negative for allergies, the tester injects a dilute solution of an antigen intradermally. A positive reaction is based on the size of a raised wheal with localized redness that forms where the antigen was injected. In the case of a tuberculin skin test, only the area of induration, the hard raised area, not including the reddened area, is measured. Identification of food allergens. To identify food allergens, meticulous record keeping of symptoms and a food diary listing all foods and beverages consumed are necessary. Skin testing and blood tests for IgE antibodies provide more objective data. Elimination diets try to establish a cause and effect relationship. The client completely avoids suspected food for 1 to 2 weeks and then adds them back to the diet one at a time and in small amounts. That way, if symptoms develop, the offending food can be identified. Because elimination studies are subjective, clients may experience symptoms based on their expectations, not from a true allergy. Clients who have experienced severe allergic reactions should not use elimination diets. Complications. Clients with inhalant allergies such as seasonal or allergic rhinitis, also known as hay fever, may develop nasal polyps from the chronic inflammation. They are prone to sinus infections related to chronic nasal congestion. Secondary pulmonary infections such as bronchitis also occur. Asthma develops in some clients. The most severe complications among persons with allergies, regardless of the type, are anaphylactic shock and angioneurotic edema, which can be lethal without immediate medical interventions. Medical management. The treatment used to relieve allergic symptoms depends on the type of allergy. Besides avoiding the allergen if possible, many clients experience symptomatic relief with drug therapy. See page 563 in Timby. To protect against poison ivy, a skin allergen, clients can apply Ivy Block, the brand name, to the skin 15 minutes prior to exposure and at least every 4 hours as long as risk of exposure continues. The cream forms a protective layer on top of the skin. The oral drug, Trentol, may decrease the rash slightly, but clients must take it before exposure. Desensitization is another option. Desensitization is a form of immunotherapy in which a person receives weekly or twice weekly injections of dilute but increasingly higher concentrations of an allergen without interruption. Repeated exposure to the weak antigen promotes the production of IgG, an antibody that blocks IgE so it cannot stimulate mast cells. When the maximum dose is achieved after 2 to 4 months of treatment, maintenance injections are administered at longer intervals, usually every 2 to 4 weeks. It may take several years before a person treated with desensitization experiences significant relief. After a desensitization injection, the client is observed for 30 minutes to assess for allergic symptoms. Epinephrine, also called adrenaline, is administered if a severe reaction occurs. Desensitization for poison ivy, oak, or sumac currently is unavailable. Clients with severe allergies to bee venom are advised to carry an emergency kit that contains a pre-measured dose of injectable epinephrine, also known as an EpiPen. The syringe auto-injects the epinephrine when pressed to the skin. The lateral thigh is the site most commonly used for injection. See page 565, figure 34-7. Recently, sublingual swallow immunotherapy, called SLIT, has been used for desensitization against allergens that cause allergic rhinitis. When SLIT is used, a self-administered solution or tablet containing grass and pollen allergens is placed under the tongue once a day during allergy season. A caregiver can administer SLIT for those who are too young for self-administration. These allergens do not generally produce a serious systemic allergic reaction because the sublingual mucosa has very few mast cells. The cells in the oral mucosa present the antigen to regulatory suppressor T cells that inhibit the inflammatory allergic response. Consequently, a tolerance to the allergen develops. Repeated SLIT results in a reduction of symptoms associated with allergic rhinitis and asthma in children with hay fever. Children tend to prefer SLIT to desensitizing injections. Nursing management. The nurse asks each client about the existence of any allergies. If any are reported, the nurse flags the medical record and applies a wristband with the appropriate information. Throughout the client's care, the nurse observes for signs of an allergic reaction, especially when administering medications, applying substances such as tape or adhesive patches to the skin, using latex products, or caring for a client receiving contrast media for diagnostic testing. If the nurse suspects a mild allergic reaction, he or she removes or withholds the offending substance and notifies the physician. If a client has an anaphylactic reaction, the nurse acts immediately to stop the client's exposure to the allergen, summons the code team or calls the 911 operator, and provides life support. Occasionally, the nurse needs to remove a ring from a swollen finger. If applying soap or oil to the finger proves unsuccessful, the nurse may wrap the finger with twine, dental floss, or narrow elastic. Once the tissue is compressed, the proximal free end of twine is slipped under and over the ring. As the twine unwinds, the ring will slip off the finger. This technique is preferable to damaging the ring with a metal cutter. If nothing else facilitates ring removal, however, cutting still is a better option than allowing tissue damage from ischemia to develop. The nurse instructs clients who are scheduled for diagnostic skin testing to avoid taking prescribed or over-the-counter antihistamines or cold preparations for at least 48 to 72 hours before testing. Doing so reduces the potential for false negative test results. Clients must temporarily discontinue some medications for even longer. In addition to antihistamines, other drugs can alter results of allergy skin testing. These include topical glucocorticosteroids, you want to stop for 3 weeks, tricyclic antidepressants, stop for 7 to 14 days, benzodiazepines, stop for 7 days, H2 blockers, stop for 2 days, Zolar, stop for 6 months. The nurse assists the provider who performs diagnostic testing and helps document findings. Once the test is completed, the nurse monitors the client's response until it is safe for the person to go home. For clients who elect to undergo desensitization, the nurse administers the serial doses and monitors the client for 30 minutes after administration. He or she teaches clients who are being desensitized and those who choose drug therapy for relief of their allergy symptoms how to self-administer prescribed medications, especially those that are delivered by metered dose or dry powder inhalers, because many people use these incorrectly. The nurse must make clients aware of possible side effects and when a medical follow-up is necessary. Techniques for avoiding or reducing exposure in the client's home and work environment are nursing areas for health teaching. Some examples include the following. Insist that the environment be smoke-free when a person manifests inhalant allergies or respiratory symptoms. Keep pets outdoors or at least in one confined area of the home. Bathe pets weekly or at frequent intervals. Cover the mattress and box springs with an impervious material to reduce dust mites. Eliminate area rugs. Contract with an exterminator if cockroaches or other vermin are present. Clean humidifiers and heating and cooling ducts to remove mold spores. Pharmacological considerations. Closely observe a client with allergies each time a new drug is added to the therapeutic regimen. This includes drugs given by the nurse and drugs used for diagnostic studies, such as radiopaque dyes. Continue monitoring the client when a second dose of a new drug is given, because reactions may follow the first sensitizing dose. Many antihistamines cause drowsiness, although some newer antihistamines are less likely to do so. Advise the client not to drive a car, operate machinery, or perform tasks that require alertness when taking antihistamines that reduce alertness. Tell clients not to take antihistamines with alcohol or other central nervous system depressants because additive sedative effects can occur. Advise clients with disorders of the lower respiratory tract not to take antihistamines. For example, these drugs are administered for asthma. A drying effect may occur, making secretions thicker and more difficult to expectorate. Suggests that clients avoid the use of non-prescription eye preparations to reduce redness. An ophthalmologist should evaluate and treat itching and redness of the eyes because the symptoms may or may not be caused by an allergy. Client and Family Teachings, 34.1, page 567. The nurse teaches clients who have allergic disorders and their family members the following guidelines. Never begin smoking or quit if you are currently smoking and if your allergy causes respiratory symptoms. Understand that treatment for chronic allergic disorders such as allergic rhinitis and food allergies may extend over several years. Follow the medical regimen as prescribed by your physician. Do not overuse nose drops or sprays for nasal congestion. Use only prescribed or recommended drugs and only in the dosage suggested by the physician. Keep a record of symptoms or lack of symptoms. Bring the record to the physician's office or clinic. The record will help the physician determine therapy. Keep a record of symptoms or absence of symptoms each time you add a new food to the diet. Add new foods to the diet slowly and one at a time. Avoid environmental substances that cause allergic reactions. Seek immediate attention if the symptoms worsen or new symptoms appear. Carry identification such as a medic alert card or bracelet to inform healthcare providers of allergies, especially if you have a history of anaphylactic reactions. Do not miss an immunotherapy appointment. Missed appointments may necessitate restarting the series of injections. Check pre-filled syringes that contain epinephrine for an expiration date. You must refill the prescription and discard the old prescription on or immediately before this date. Keep the directions for use with the product. Medical identification bracelet. When educating the parents of a child diagnosed with a severe food allergy, the nurse should emphasize the importance of the child wearing a medical identification bracelet. Gerontological considerations. Adverse reactions to antihistamines such as dizziness, sedation, and confusion are more common in older adults, necessitating careful assessment and monitoring. Beer's criteria, a reference that identifies prescription drug safety issues for older adults, is helpful for evaluating potential risks and benefits commonly experienced because of changes from aging. For example, older men with benign prostatic hypertrophy may experience difficulty voiding while taking antihistamines due to anticholinergic side effects. Question. A nurse would evaluate that the client understands what triggers allergic rhinitis by which of the following client responses? A. Injected medications. B. Topical creams and ointments. C. Ingested food and medications. Or D. Airborne pollens and molds. The answer to the question is D. Airborne pollens and molds. Airborne pollens and molds are inhalants which commonly trigger allergic rhinitis. Autoimmune disorders. Autoimmune disorders are those in which killer T cells and autoantibodies attack or destroy natural cells, those cells that are self. Autoantibodies, antibodies against self-antigens, are immunoglobulins. They target histocompatible cells, cells whose antigens match the individual's own genetic code. Gerontological considerations. With age, cells within the body decrease in sensitivity, which interferes with the recognition of self from non-self, from foreign components. This change increases the risk of autoimmune disorders, such as lupus. As a person ages, higher levels of autoantibodies may be directed to endocrine glands, so attention to symptoms of hypothyroidism and hypopituitarism is important. Diseases are considered autoimmune when they are characterized by unrelenting progressive tissue damage without any verifiable cause. Various specific disorders classified as autoimmune are discussed throughout this text. Refer to Chapter 37 for information on MS. Chapter 58 for discussion of acute glomerulonephritis, and Chapter 63 for coverage of rheumatoid arthritis and lupus. The term alloimmunity is used to describe an immune response that is waged against transplanted organs and tissues that carry non-self antigens. See Chapters 29 and 58 for more information. Pathophysiology and etiology. Causes. Tissue injury theory is the theory that infection, trauma, or introduction of a drug that integrates itself into the membranes of the host cells are the cause of CFS. Example, streptococcal infections and rheumatic heart disease. Genetic instruction theory, genetically predisposed to autoimmune disorders, or other sequestered antigen theory. Assessment findings. Signs and symptoms. Autoimmune disorders produce various signs and symptoms depending on the tissues and organs affected. The symptoms are characteristic of an acute inflammatory response. They develop as antibodies and attack normal tissue mistakenly identified as non-self. In some cases, the inflammatory symptoms are episodic. Periods of acute flare-ups known as exacerbations alternate with periods of remission, which is asymptomatic periods. The duration of these periods is completely unpredictable. During acute exacerbations, clients often experience a low-grade fever, malaise, or fatigue. They may also lose weight. Diagnostic findings. Diagnostic testing varies depending on the autoimmune disorder. Overall, elevated circulating antibodies are the hallmark findings for autoimmune disorders. Some examples include elevated erythrocyte sedimentation rate, anti-streptolysin O titer, anti-nuclear antibody titer, and rheumatoid factor. Medical management. Autoimmune disorders are rarely cured. The goal of therapy is to induce a remission or slow the immune system's destructive activities. Drug therapy using anti-inflammatory and immunosuppressive agents is the mainstay for alleviating symptoms. See Drug Therapy, Table 34.2 on page 571. Some anti-neoplastic cancer drugs are also used for their immunosuppressant effects. Controlling or limiting side effects of the drugs, one of which is increased susceptibility to infection, is a major concern. Even with remission, most people must continue taking prescribed medications to avoid another acute exacerbation. Pharmacologic considerations. When taking drugs to suppress the immune system, the client has an increased risk of infection, especially of the respiratory or urinary system. Observe such clients for signs and symptoms of infection such as fever, sore throat, productive cough, and dysuria. Drug therapy includes immunosuppressive agents such as Sandimmune and Prograf. Cytotoxic agents such as Imuran, IMURAN, are used, and corticosteroids such as prednisone are used. Nursing management. Obtain a family history during the initial interview with the client and be alert to information about family members who have had chronic diseases with an inflammatory component that involve cardiac, urinary, neurologic, or connective tissues. During acute exacerbations, the client is quite ill. Note elevated vital signs, a finding that suggests an infectious or inflammatory process. Examine the client for signs of localized inflammation and compromised body functions, such as changes in the skin, joints, gait, heart, and renal function. Ask about the client's level of energy because fatigue is common. Review laboratory test findings for evidence that correlates with an inflammatory response or immunologic changes typical of one of many autoimmune disorders. Diagnosis, planning, and interventions. Activity and tolerance related to joint pain secondary to inflammation, malaise, and fatigue. Expected outcome. The client will perform activities of daily living without extreme fatigue or discomfort. Encourage rest during periods of severe exacerbation and regular exercise during periods of remission. Activity levels within a client's level of endurance promotes well-being. Endurance is related to the frequency, duration, and intensity of activity. Provide non-pharmacologic and pharmacologic pain intervention and management as ordered by the physician. Non-painful stimuli such as massage, activity, heat, cold, imagery, pleasant sounds can reduce or relieve pain. Analgesic, anti-inflammatory medications block neurotransmitters that carry the pain stimuli to the brain. Narcotic analgesics dull the brain, making it less perceptive to pain transmission. Corticosteroids suppress the immune response. Risk for infection related to immunosuppression secondary to drug therapy for the autoimmune disorder and generally poor physical condition. Expected outcomes, the client will be free of infection. Instruct the client about signs and symptoms of an increased risk for infection. Access to knowledge facilitates an active role in restoring health. Instruct the client to report signs and symptoms of infection such as cough, dyspnea, diarrhea, fever immediately to the physician. Early treatment promotes a shorter duration of illness and reduced complications. Tell the client to avoid high-risk activities such as being in crowds during periods of immunosuppression. Risk for infection increases with exposure to others who may have infectious disorders or whose hand washing and hygiene measures are less than adequate. Disturbed personal identity, related to coping with chronic illness and physical change associated with autoimmune disorders. Expected outcome, the client will maintain a positive self-concept. Interact with and frequently show genuine interest in the client. A person's concept of self is determined to a great extent by the responses of others. The client may interpret lack of interest and avoidance as a rejection and being unworthy of attention. Refer the client to community organizations and support groups. Sharing problems and experiences with others who are similarly affected dispels the idea that a person's symptoms and feelings are unique. A person can more easily resolve and tolerate problems when he or she shares the burden with others. Evaluation of expected outcomes. The client participates in self-care and ADLs without overwhelming fatigue. There is no evidence of iatrogenic treatment-caused infection. The client perceives himself or herself realistically with more positive attributes than negative. Chronic fatigue syndrome. Chronic fatigue syndrome, CFS, also called chronic fatigue immune dysfunction syndrome, and myalgic encephalomyelitis, is a complex of symptoms primarily characterized by profound fatigue with no identifiable cause. The fatigue worsens with physical activity and does not improve with rest. The term chronic refers to the fact that the duration of fatigue has been unrelenting for 6 or more months. Some believe that chronic fatigue syndrome is somewhat like fibromyalgia because both conditions share many symptoms, such as pain in fibrous tissues of the body, such as muscles, ligaments, and tendons. Estimates are that as many as 1 to 4 million people in the U.S. have symptoms corresponding with chronic fatigue syndrome, but fewer than 80% have been diagnosed by a medical provider. Most clients who seek treatment for their symptoms are white women 40 to 59 years of age. Chronic fatigue syndrome also occurs at lower rates among children, adolescents, and men. Statistics for minorities may be low when taking into account their reduced access to the healthcare system. It is difficult to determine the duration of chronic fatigue syndrome or recovery rates because the disorder has a pattern of unsustained remissions followed by exacerbations. Some people with CFS improve but are not completely symptom-free, while others continue to suffer, sometimes for decades. When the duration of symptoms is lengthy, the prognosis is less optimistic. Gerontologic considerations. Chronic fatigue and diminished energy are functional consequences of late life depression that are reported by approximately 70% of older adults. Client and family teaching, autoimmune disorders. The nurse teaches clients who have autoimmune disorders and their family members the following guidelines. Notify a healthcare provider of any sign of infection such as cough, fever, severe diarrhea, mouth lesions, or sore throat. Notify a healthcare provider of any new side effects to prescribe medications. Do not stop taking any medicine abruptly. Avoid crowds or people with infections if you are taking an immunosuppressant drug. Limit stress and use stress reduction techniques such as progressive relaxation or breathing exercises. Maintain close follow-up with the physician. Pathophysiology and etiology. No cause for CFS has been yet established, but those affected exhibit a deficiency in adenosine triphosphate, ATP, the source of cellular energy. Some believe that the disorder results from immune system dysregulation, in which the immune system remains activated for an extended period after an infectious triggering event. Although researchers have attempted to find a link between CFS and viral diseases, no single causal relationship has been found. Some hypothesize that T cells are activated initially in response to a virus, and the levels of pro-inflammatory cytokines such as various interleukins and tumor necrosis factor remain elevated. It is well documented that cytokines or kines produce achy, flu-like symptoms accompanied by fever and malaise during the early stages of infection. People with CFS experience these same symptoms. The difference is that during infections, the symptoms are brief, but in CFS, they are relentlessly prolonged. Evidence is mounting that CFS is caused by a combination of a genetic predisposition, a triggering event such as a viral or bacterial exposure, and an atypical immune response. It has been found that people with CFS produce a defective form of ribonuclease termed RNase-L, an enzymatic protein produced by the cytokine interferon that has antiviral activity. RNase-L destroys the RNA in viruses as well as in normal cells. The RNase-L attacks the wrong enemy. It attacks normal body cells and leaves the person subject to reactivation of viruses that should remain dormant. Some believe that CFS should be called chronic viral reactivation syndrome. The fact that serum cortisol levels are low among those with CSF symptoms has led to another hypothesis. Some believe that a CSF is a consequence of impaired activation of three neuroendocrine structures: the hypothalamus, pituitary gland, and adrenal glands. Collectively, these structures are sometimes referred to as the HPA axis. The adrenal glands secrete corticosterone, which is cortisol, which suppresses inflammation and immune activity. Downregulation of the HPA axis interferes with immune suppression and allows the hyperfunctioning immune process to continue. Downregulation of the HPA axis also helps explain why those with the CFS experience orthostatic intolerance. Orthostatic intolerance is a condition in which individuals experience hypotension accompanied by fatigue after standing for more than 10 minutes. Signs and symptoms. Many clients with CFS report having had a recent illness with flu-like symptoms or upper respiratory infection. Despite having been uncomfortable, most clients do not describe their initial symptoms as being extraordinarily severe. In fact, the opposite is true. Therefore, severe ongoing fatigue has lasted for at least 6 months without any explanation. Even though the fatigue is constant, it worsens after physical activity. The fatigue is so debilitating that it usually interferes with the person's ability to work in or outside the home. According to the Center for Disease Control and Prevention, in 2012, in addition to fatigue, the client exhibits at least 4 or more of the following: malaise that lasts more than 24 hours after an exertional activity, sore throat that is frequent or recurring, tender cervical or axillary lymph nodes, joint pain without swelling or redness, myalgia, which is muscle pain, headaches of a new type, pattern, or severity, unrefreshing sleep, and significant impairment of short-term memory or concentration. Diagnostic findings. Findings of the medical history and physical exam are unremarkable. Results from a battery of blood tests specific for diagnosing diseases associated with fatigue fail to reveal an explanation for the client's symptoms. The exhaustive medical workup excludes all diagnoses except CFS. Currently, research is focused on measuring levels of RNase-L in CFS. The knowledge that the enzyme is elevated in clients with CFS has not improved diagnosis of the disorder. Recent research at Cornell University found a correlation between intestinal bacteria and inflammatory microbial agents in blood that trigger an immune response, but it's unknown at this time if the results indicate a cause or consequence of the disease. A tilt table test, one in which the client lies horizontally on a table whose incline is elevated to approximately 70 degrees for 45 minutes, may be done. During the test, the blood pressure and pulse are monitored. The test tends to provoke hypotension in those eventually diagnosed with CFS and may be a diagnostic marker. Medical management. Treatment focuses on relieving the client's symptoms because nothing as yet holds promise for a cure. Without a disease-specific drug, most are treated with medications such as analgesics, antidepressants, and central nervous system stimulants that only manage their symptoms. Ampligen, an investigational drug for CFS, has been through repeated clinical trials. It is a synthetic RNA that stimulates the production of interferons that have antiviral functions and modify the immune response. During clinical trials, Ampligen has shown to produce improvement in activities of daily living, decreased fatigue, improved activity performance, reduced polypharmacy, and a decrease in disease progression, yet the drug has not still fully acquired full FDA approval. After the drug manufacturer resubmitted an analysis of its data showing Ampligen had no significant safety issues, the FDA is requiring more statistics on the drug's efficacy. Manufacturers of NADH, a nutritional supplement known as ENADA, ENADA, claims that it stimulates the production of ATP, which provides cellular energy. After 1 year of taking ENADA, ENADA, approximately 81% of those in a clinical trial conducted at Georgetown University Medical Center, Washington, D.C., reported more energy and improved mental cognitive status. Without any definitive drug treatment, the client is advised to balance activity with rest. An employed client may need to resign from his or her job or negotiate for a less physically demanding position. The physician may prescribe a modest exercise program under the supervision of a physical therapist to avoid muscle atrophy that contributes to the weakness. The client is to avoid overexertion. Mild pain and fever are treated with aspirin, acetaminophen, or non-steroidal anti-inflammatory agents such as ibuprofen, Motrin, Advil, or naproxen sodium, naproxen, or Aleve. Even low doses of tricyclic antidepressants such as Elavil, Sinequan, or Pamelor can relieve pain and improve sleep. Nursing diagnosis: the client with chronic fatigue syndrome. Some studies suggest that people with CFS may be marginally deficient in various nutrients, including B vitamins, C, magnesium, zinc, and essential fatty acids. It's not known, however, whether nutrient deficiencies come before CFS or are a consequence of the disease process. Because the potential benefits outweigh potential risks, a multivitamin and mineral supplement may be a good choice. An omega-3 fatty acid, known as EPA, is thought to block the release of cytokines and prostaglandins and therefore may prevent or reduce inflammation and pain experienced with CFS and other inflammatory autoimmune disorders. Fish oils provide the only dietary source of EPA. Fatty fish such as mackerel, sardines, herring, salmon, and tuna are the best sources. Fish oil supplements usually are not recommended because no clearly prescribed guidelines on the optimal dose are available. Also, fish oil supplements have the potential to cause GI upset, increased bleeding time, vitamins A and D toxicities, and decreased levels of various immune system components, the significance of which is uncertain. Clients who experience orthostatic intolerance are advised to increase salt and water intake as long as doing so is not contraindicated by cardiac or renal disease. Some clients also experience greater blood pressure stability when Florinef, a corticosteroid, is prescribed. An antihypotensive such as proamotine may be prescribed to increase vascular tone and elevate blood pressure. Several adjunct and alternative therapies are suggested to treat clients holistically. Some clients benefit from cognitive therapy, a form of psychotherapy in which people learn skills to change distorted thoughts about themselves. For example, cognitive therapy may help a person with CFS who believes that he or she is a helpless victim of the disease to perceive himself or herself as capable of dealing with the fatigue. Some promote the use of acupuncture. Eastern exercise and meditation techniques such as yoga and Tai Chi and phototherapy contribute to well-being. Until more information is known about CFS, clients may fall victim to herbal and dietary claims that promise a cure. As long as alternative therapies are not dangerous, the client's right to incorporate unproven or non-standardized methods is not challenged. Nursing management. The nurse educates the client about his or her disease process and the limitations that it requires. Page 576 is an example of a care plan for the client with chronic fatigue syndrome. You want to help perform ADLs during periods of peak energy, schedule rest periods every hour or more, and the outcome desired is that the client's fatigue will be reduced to manage her activities of daily living. Another nursing diagnosis is chronic pain. Apply cold or warm packs to joints or muscles, encourage floating in tubs or pools, and the outcome is that the client's pain is reduced to tolerable levels. Question. The client diagnosed with chronic fatigue syndrome is at risk for injury related to neurally mediated hypotension. To maintain the safety of the client, the nurse should do all the following except A. Keep the signal for assistance within reach. B. Apply elastic stockings. C. Administer the prescribed hypotensive or corticosteroid medications. Or D. Encourage the client to relax in a tub of tepid water for 15 minutes. Submersion in water results in buoyancy, a feeling of weightlessness, and relaxation, and does not prevent hypotension. So D, encourage the client to relax in a tub of tepid water for 15 minutes. This is the end of the slideshow.